That was great. Can I invite the other speakers up to the podium, and hopefully Dr. Brawley can stay around a little bit longer.
Absolutely. Absolutely.
Thank you all for your talks this morning. I think, as we said at the outset, we have framed this in a way to really take all we've learned in integrated diagnostics, imagine that that is a possible future for us, but make sure it can improve the health for everyone. And whether that's in training the right algorithms, delivering it to the right communities, and building that trust that allows it to really be taken up by everyone who can benefit from it. So I see we already have a question here, so please state your name.
Sure, George Weiner from Iowa. A question for Dr. Brawley. So we've been hearing throughout the past day and a half or so about AI and using it to identify patterns across platforms that we didn't recognize. Has AI been used to identify causes of disparities across platforms that we haven't recognized before? You gave some great examples, but I wonder if we're applying AI to find others.
Good morning, Dr. Weiner. That is a wonderful question. I do not know where AI has been applied to healthcare disparities or health equity. I honestly do not know of an instance. Maybe someone in the audience does, but I think that's a wonderful question.
Okay.
Something for us all to think about. Perhaps I'll just extend on that for a moment to Dr. Brawley. So thinking about the data sets that you need to train, and your microwave analogy and my car light analogy were really quite compelling. But when we look at the large data sets we have of molecular profiling, of radiology imaging, how has that been teased out across so that we can learn from those data sets across racial ethnic disparities?
So, first of all, I would like to follow up to that question. Many times we couldn't, with AI or other techniques, actually make this kind of studies because the data sets that are currently available are extremely biased in their composition. And I want to mention the first example of such data set is the one that we use to develop CBIL, which is an LST data set, which is a low dosage CT. In that particular data set, it's predominantly white. I think it has 2 or 3% African American and 2% Asian. So in this kind of composition, it's really hard to do any discoveries about disparities. At the same time, in other data sets, especially molecular data sets, there's a techniques that are very briefly discovered of kind of identifying different population within the larger population. We already see that this technique can discover and identify population which we would not necessarily think about, because we can very easily take any population, use standard methodology to break them by race and by age and by gender and so on. But there can be some other things about other types of disparities that we are not even aware, so we would not report on it. That's why it is important to use these AI techniques that can identify out of distribution population and then go back to the medical practitioner or people from the population health and ask back and say, what's so different about this population that it's not distributed in relation to the outcome as the rest of the population. So I think that talking about, to Wendy, about the work that happens in NSF and algorithm development, I think really switching it from our own intuition, which sometimes is limited, to the algorithmic ways to define who are those which are different is really a way forward. And there is a lot of work both on methods development and demonstration on the data sets.
The AI will help improve our implicit bias, perhaps.
Absolutely.
Dr. Nguyen, did you have a question? Oh, I'm sorry.
Yeah, that's fine. I'm David Dorr from Oregon Health and Science University. So one of the things that I was struck by here is that there are pretty stark disparities in the access to and availability of the resources we need to address inequities, whether, the skills and knowledge to develop robust algorithms in the way you describe, or, getting certain kinds of care or technologies out to communities, and of course, the broad issue of inequities. And I sort of feel like it's always all of our jobs to address that. And I wonder if the people could give for the audience, like, what should we all be doing from your perspective to really reduce that disparity?
Thank you for that. Do each of the speakers want to just address that for a moment?
Yeah, if I could. The disparities are all not within the healthcare providers are not the answer to the whole question. Some of my work in terms of colon cancer, risk reduction or death rate reduction shows that we've had a 65% reduction in death rate from colorectal cancer in Massachusetts since 1980, and a 15% reduction in Mississippi. Some of these problems are going to require political action, and unfortunately, I don't see much political will. What I'm saying is doctors, nurses, healthcare providers, hospital administrators can go part of the way, but some of the issues are actually in the fabric of society beyond the purview of doctors, nurses, and healthcare administrators.
Thank you. Randy?
Boy, that's a big concept and a big question. So I certainly agree with Dr. Brawley's comments. I think we need a national healthcare system, one that provides universal healthcare to everyone. But as Dr. Brawley said, there's so much in the realm of health-related social needs that really undermine the innovations that we have in healthcare, and that's an entirely different matter. As far as what we can do, well, we all need to bring the best treatments, best methods to our communities, and provide to the patient in front of us without bias each and every day. And like Otis said, we're going to need some political will. It's a much bigger issue than medicine. And the same health-related social needs, I think, undermine our educational system as well.
So I just want to, again, emphasize the importance of creating the balanced data set that represent all of us. And the new initiative of creating such a data set, all of us, is really one important step forward. We need to be very honest when we are publishing from the data sets that are historical data sets that come from NCI and other sources, which are biased, biased in their composition, not a data set biased. And I also think that it's really an important thing for NSF and NIH to ensure that we put sufficient resources in development of the algorithms that can ensure that our next generation AI systems are working well across different population and can handle the minority population well.
Thank you. And I think with the last ARPA-H presentation, perhaps this is the BHAG that we really need them to embrace as we move ahead.
Good morning, everybody. And this is Dr. Nguyen from VCU Massey, and good morning, Dr. Brawley. The question I have is, conceptually, we are very comfortable with the concept of food deserts. But the interesting thing, in almost every data conference I've now been to, it is if we don't recognize or don't talk about, or it's in the corner, the concept of data deserts. And so in the context of our aspirational thing of the better data sets, you're going to be limited in the context of your data desert. So one of the questions that I actually have for you, and maybe the answer is in the hub and spoke, not just for healthcare, but the hub and spoke sort of model in the context of data, or maybe just like the 1861 Mural Act of the land grant, where you're literally putting people out in the communities, then the rural communities, to do things. We may have an opportunity of addressing those data deserts. What's the workforce of tomorrow or of today that can help us reduce the data deserts? So that's the first question. And the second one may be a little bit harder, but I'm going to ask it anyways. How do you then prevent us from having a two-tiered AI system, just like your radiation oncology, as we just heard, where you actually have the access to radiation, but the access is not the same? Because all AI is not going to, again, a hood, just a good second. This is a hood example. Someone once pulled out their cell phone. They said, this cell phone is changing America. I could even get my EKGs. I can even my ultrasound. I go, well, have you ever been on the south side of Chicago up in Inglewood? They don't have, their cell phone does not do the same thing your cell phone does. So quit talking about just the technology and start talking about really the actualization of what the technology is capable of doing in those communities. Because I think that we sometimes fool ourselves by just saying that the issues are there, just like the radiation. So the first question really comes back to, how do you address the data deserts? What's the workforce or at least the infrastructure to figure out how to make that smaller? And second, how do we prevent actually having a two-tiered AI system, one for folks who can get to our academic centers and then an AI for everybody else? I'm sorry to wake up this morning and doing that.
No. Dr. Nguyen, my dear friend, you have this gift for coming up with key phrases like data desert. And you're absolutely correct. My concern, and I don't have an answer to your question. They're both very good questions. My concern is in many hospitals and many clinical settings, especially, I grew up in safety net hospitals, we are building the airplane as we are flying it. And as we incorporate this extra work, it's going to make it harder to do the stuff that we've already been doing. I just worry. I'm not saying don't do it. I'm not saying don't do it at all. But what I'm saying is, if we're going to try to cure those data deserts, we need resources so that we can continue doing the things that we've already doing. I'll go back to my lung cancer screening example again. There are people who want the Grady hospitals of the world, the inner city safety net hospitals to do lung cancer screening. All lung cancer screening does is benefit a few people while making the line for the CT scanner longer for everybody else who needs it. It worsens the quality of care. And I'm afraid that as we start doing more and more, we're going to worsen the quality of care. It's not that I'm against doing it, but that's what I worry about.
Thanks. Why don't we go ahead? I know that we're running short on time, but let's try to get everyone who's up at the mics to be able to speak.
Thank you very much. I'm Manuel Saltoteyes from ICR and Royal Marsden in London. Excellent presentations. Thank you very much. A question for Regina. So what is the minimum area under the curve necessary and sufficient for an AI algorithm, a predictive AI algorithm, to be clinically meaningful?
So thank you for this question. Actually, it saves me from arguing directly with Dr. Brawley about the importance of screening, so I can combine the two. So I think that the question that we need to be asking, not what is this number in absolute, but how does it compare to the current standard of care that we have? So in breast cancer risk assessment for the general population, TerraQC, Gale model, and others are what is used. And as people here who are oncologists know, you can get a supplemental screening and other things, or even tamoxifen, based on these models. So if you can move the AUC, which is currently of this model around 63, to 77, I would say yes. But I would say even if it is half of this difference, if you can better identify population at risk, there is absolutely no reason not to use them. And currently we are doing clinical trials both in breast, and Lisha Sequis, who is my collaborator at MGH, the thoracic oncologist, she's starting clinical trial on lung cancer in a variety of community settings as well, to really identify how do you incorporate them in the clinical pipeline so it makes a difference. And I think we currently have this big disconnect. There are people like me who develop methods, and then there are clinicians who have some experience in applying AI, but we really need to find protocols. How do you take this technology in a safe way and find what is this number, what is needed, and what are the extra tools that you need to ensure that it is safe and robust? So it's like a longer answer without concrete number, but I really hope that in several clinical trials we would be able to say, is the current increase in accuracy sufficient to change long-term patient outcomes?
Thank you.
Dr. Schulman, did you have a question?
Yeah, Larry Schulman, University of Pennsylvania. Great talks. Randy, I had a question for you. You talked about the benefits of smaller hospitals being part of a network or a hub and spoke model. You're part of one of those health systems. I hope it's beneficial for you. But a large majority of the smaller hospitals in rural areas are not part of a network or a hub and spoke, and that may be where the greatest disparities of care occur. And we haven't, we're talking about lack of national will over and over again, but we haven't had a plan at the national level really to try to confront that issue. And you might say from hospitals like mine, an academic center, it might be part of our responsibility to figure out how to partner with those hospitals and raise the care. But what are your thoughts? I mean, you represent ACCC and a lot of these places. What are people thinking?
Thanks, Larry. So as Larry mentioned, I work at a community hospital that is part of the University of Pennsylvania network, which gives us access to resources. I think that somebody mentioned yesterday that some changes need to come from the top. I think that there needs to be commitment from the NCI, perhaps for the core grants that go out to our NCI designated cancer centers, perhaps for a new structure. We're not going to actually put people in communities where they don't elect to live and work, but I do think that we can put programs and electronic resources, whether they're digital. I appreciate Dr. Wynn's comments. When I looked at the maps I showed, I thought of, deserts for distribution of cancer centers. I mean, that's what it looked like to me. You made a lot of important comments, Rob, and I think that it just can't be business as usual. And as we heard today, some of the progress that we need shouldn't be incremental. It should be transformative. And we're not going to tinker with this problem and have it go away. I think we need some bold solutions, whether it's, academic organizations have an increased responsibility for community outreach and distant partnerships, or whether it comes through the NCI or some other mechanism. I think it's time for a big change.
Yeah, I would just add that at one of the previous workshops, somebody from the NCI showed all the comprehensive cancer centers and their catchment areas, which is what the CCSG requires us to pay attention to. And then there were vast areas of desert, if you will, between those catchment areas. So we currently have designed a system for a variety of reasons that, in fact, doesn't address those areas.
Perhaps we should be looking at the map and looking at the desert and saying, who's responsible for this? Who's going to take this on and provide the resources, the infrastructure, and the help to make sure that these parts of the country and the people who live there are covered?
Thank you. Thank you. One last question before our break.
Hi, Joe Leonard's Mass General. I have a somewhat provocative question. As we define integrated diagnostics, we probably also have to define what it is and what it is not. So I think some of the points raised about prevention and screening are just a general access problem. Let's just pick mammography, right? Do we have everyone covered with that? So the question I'm asking is, do we really need integrated diagnostics for everything, or is it sometimes just having access to the right diagnostics that we have at hand? So it's a little bit provocative to say, do we really need integrated diagnostics for prevention and screening, or do we just need normal good prevention and screening diagnostic tests?
I would go one further and say we need integrated diagnostics and treatment. One of my most cited papers talks about how 7% of the black women and 2% of the white women in metropolitan Atlanta who were diagnosed with curable clinically low stage breast cancer got no treatment in the first year. And that was about 2006, 2007. So, we have when we talk about health disparities, we have a substantial number of people who already get the diagnostics and then don't get the treatment. Again, a very good question. But we need to think about the entire thing, not just diagnostics.
I think that's where risk assessment comes in, so that people have access to the care that they need and we're not providing or overdoing it where it really doesn't make a difference. And I would suggest that in addition to radiomics, genomics, pathology, that we make sure that health-related social needs that are so determinative of what screening people need and how they respond to treatment, that those are part of the equation as well.
So if I may just add to this point about mammography and other things. So there were a lot of studies during COVID when mammography was limited, which demonstrated the population that actually got access to these limited resources was not necessarily a population that really needed to get access, priority access. We similarly know that MRI distribution, lots of articles published that patients who really need MRI don't get MRI, and patients who don't need it get it, and many times it's driven by patient desires rather than by what's really needed. So I firmly believe that one direction in AI diagnostics is actually making it more complex and kind of utilizing more factors. But another one is to have much more algorithmic approach of really assessing risk and acting upon it. So we really understand, based on the raw facts, who is it that is at risk, and providing more expansive resources for those patients independently of their, socio-economic status maybe, but really looking at what, from the medical perspective, which one needs to get there. And I believe that as our models across the spectrum for diagnostics are going to be stronger with AI which is not biased, we can at least resolve some of this concern.
Thank you. So integrated diagnostics will help all of us. And that's the goal. I want to thank our speakers. I want to thank Wendy Nielsen, who's been helping me take the notes, since we're going to have the readout just after the break. We have how long? What time do you want everyone back here? No break. No break. So we're going to just stand up, stretch our legs, sit down, and we will go ahead and have the last session according to our jefes here today. And thank you, everyone.